Anila, tell me when I have to start, okay? So, hello students, I'm Dr. Khushbu Mahajan. I'm your dermatology faculty from Bhatia. So, in this session today, I will be talking about one of the very common topics, which is sexually transmitted diseases, how to approach it, and what questions do you get from STD, and how do you actually approach a question which you get from STD. So here broadly, I'll be covering most of the STDs that are asked, and this would be more of an approach-based session where I will be telling you how, based on what questions do you get, what history do you get, what examination findings have been given to you, you arrive at a diagnosis. Okay, so it's not just about a particular disease, it's in general about how to approach a case of STD. Right. So when we are talking about reaching a diagnosis, our diagnosis always relies on three major aspects, which is usually given in your exam also: the history, examination, and some investigations. Right. Now, in the history, it is very important. Like, what is the question asking you about? Is it a question about an ulcer, a question about a discharge, a question about genital itching, a question about genital nodules or swellings in the genital area, a question about a skin lesion which is present along with the whatever genital lesions are present, or are there any constitutional symptoms being given? So when they're giving you a question on STD, it would be broadly localized to these important presenting complaints, right? Now, how do you know that whether it is a question of STD or not? So, in the question, they give you some sort of history, some sort of reference, which points towards a sexual history, in which either they would tell you that a patient has unprotected intercourse, or the patient has multiple partners, or a patient is a truck driver, or a patient is a migrant laborer, or a patient who's staying away from the family, a patient who's gone on a leisure trip. So all these are different terms or phrases that they use when they're trying to tell you that they're referring to a STD. Okay, so please make note of these things in the question, and then automatically your mind will go towards thinking about an STD reason for that. Okay. For example, if they're talking about genital ulcer and they tell you a patient has unprotected intercourse and something like that, has multiple partners, and then in the options they give you Behçet's and herpes and fixed duct eruption, all of this can present with an ulcer in the genital area. But based on this history, you can tell that, okay, this is not Behçet's, this is not FD they are referring to. They're referring to an STD. And so you will be able to rule out some options based on what you see. Right. Then examination. So whenever they're giving you an examination, they'll be giving you either the genital area, they can give you skin lesions also. So remember, whenever a case of STD is there, there may be mucocutaneous findings also, like in a case of secondary syphilis, like a patient of herpes who can have oral erosions. Then presence of lymphadenopathy. and any other examination findings which are present. So this I already talked about. So this is also something which I was saying, that when they talk about mucocutaneous involvement, so you should be knowing that the skin lesions, if they're giving you skin lesions, which is the STD which is present with skin lesions, it would be secondary syphilis. Less commonly, it can be there with HGV, with gonococcus, chlamydia, but for your purpose, exam point of view, they hardly try to give you any other STD apart from syphilis when they are giving you some mucocutaneous finding. Okay. With gonococcal, sometimes they try to give you disseminated gonococcal infection, in which you might get acral areas which are showing fistular lesions with some arthritis. So DGI may also be given, but commonly they give you something which is related to syphilis when they're talking about skin lesions in an STD patient. So apart from genital area lesion, skin lesions are mucocutaneous lesions apart from genital area are commonly involved in syphilis. And so if that is given, think about syphilis. So I'm giving you a very take-home points or giveaway points. So if you see this, you can think, okay, I'm directed towards this particular diagnosis. Then, if they are talking about palms and soles, so again, palms and soles become relevant in which kind of STDs? One is syphilis and one is scabies. So sometimes they give you genital scabies, and genital scabies patient may also have involvement of other body parts. Though it is tried that if you have only genital scabies, think about STDs. But if you have predominant genital involvement, you still can have some involvement of palms and soles. Apart from that, again, palms and soles, most important, syphilis. We all know about BO sign, that you you press your blunt end of the awl pin on the lesions, and there is the patient winces with pain, which is called as Buschke Ollendorff sign, which is seen with secondary syphilis. Okay, so that in that you will be given either lesions on palms and soles, or you will be given a picture of lesions on palms and soles. So a lot of times when you see skin involvement, palms and soles involvement, we don't think in direction of STD. We always think that genital lesion nahi given, so it could not be an STD. So here, make sure that syphilis is one condition where there will more commonly be questions on mucocutaneous examination rather than on genital examination or genital examination. Okay. Then, mucosal lesions. What are the two common disorders where you see mucosal lesions? The most common, I would say, is herpes, because syphilis patients do present symptomatically with this. So usually with the patient of herpes, they can give you recurrent oral erosions also, because remember, we studied that HSV can cause, usually HSV2 causes below waist infections and HSV1 causes above waist infections. Okay, but it is interchangeable. I've told you again, time and again, that it's not fixed. So if there is genital herpes, which is due to HSV2, same patient can also have oral erosions, oral painful erosions. Okay, so if mucosal involvement is given, think of herpes. Secondary syphilis, again, can present with mucosal erosions or mucosal lesions. We know about snail track ulcers, that happens. We know about the erosions that we see in secondary syphilis, but important difference would be they would be painless. In herpes, they are painful. In secondary syphilis, they are painless. Okay, so that is the element of having mucosal lesions. Then lymph nodes. Lymph nodes is very, very important for all genital ulcer diseases. Okay, not so much for other kind of STDs like urethral discharge, cervical discharge, but very, very important from genital ulcer disease. So much so that at times it's only the lymph node which is given, and that is my giveaway point to establish a diagnosis. So if talking about lymph node, so I told you genital ulcer disease you should think of. So syphilis, the lymph nodes will be typically shorty, painless lymphadenopathy. So they will be painless lymph nodes and they will be shorty. So they will write this term shorty. If I'm talking about chancroid, so then chancroid is usually unilateral and painful lymphadenopathy. Herpes is bilateral and painful lymphadenopathy. Okay. LGV most commonly will present with lump in the groins. Most commonly will present with these unilocular abscesses, which you may confuse. So there is significant lymphadenopathy in secondary stage of LGV, and these lymph nodes undergo an abscess formation, and this abscess is usually multilocular, and that can present with painful lump in the groin. Okay. Dominguenosis, on the other hand, you have no lymph nodes. No lymph nodes. So if a patient of dominguenosis is given and lymphadenopathy is given, cannot be there. So if lymphadenopathy is mentioned, you have to think of other ulcers. Dominguenosis does not lead to lymph node. But there is something in dominguenosis that we see which is called as pseudobubo. What is a pseudobubo? If a dominguenosis ulcer is present over the area of lymph node, it will mimic like there is a lymph node. Okay, you think that it's a lymph node which has either burst out or there is an abscess which has burst out. So that can happen. But dominguenosis, there is no lymphadenopathy. Sometimes an ulcer of dominguenosis can happen over the lymph node, in which case we call it pseudobubo. Okay, buboes are most commonly in chancroid and LGV. Pseudobubo in dominguenosis. Herpes, I have bilateral painful lymphadenopathy. In syphilis, I have short T lymphadenopathy, which is painless. Clear? So based on what lymph node description has been given to you, you can point out that which STD we are referring to. I'll talk about the difference in buboes of chancroid and LGV subsequently. Okay. So now, moving on to specific STDs. So this is in general, that what you see in examination and in history. Then coming to ulcers. So when we talk about ulcers, we know that we have to talk about 5 main ulcers, and based on whatever history and examination, we should be able to differentiate between these 5 genital ulcers. So what are these 5 ulcers? Syphilis, chancroid, herpes, dominguenosis, and LGV. Okay. So here, I'm not going to talk about each and every disorder in detail. I'll mainly help you differentiate between these ulcers, right? Sorry, I wrote 4. There are 5. Now, why have I given a question mark over LGV? Because LGV hardly presents with an ulcer. In LGV, there is an ulcer which is there in the primary stage, but it is very transient. So patient almost never presents with an ulcer. Okay, so in LGV, in the question on genital ulcer disease, if they are giving you an ulcer, you know that they're not referring to LGV, because LGV does not, the patient usually will not present with an ulcer, because the ulcer which is there in the primary stage, it is very inconspicuous, it is painless, small ulcer which goes away on its own. So in LGV, patient usually presents in the inguino-rectal syndrome or the secondary stage of the disease. So that is why I've written a question mark over LGV. So when we're talking about genital ulcer per se, an ulcer description is there, you think of these 4 genital ulcers. So how do we differentiate on the basis of history which genital ulcer it is? So is it recurrent? So if the patient is telling me, so first of all, yes, the incubation period. So we know that when we are talking about herpes or chancroid, the incubation period will be short, 2 to 7 days, 2 to 5 days. So whenever I get such a short incubation period, I straight away start thinking about herpes and chancroid. Syphilis, the incubation period is 10 to 90 days. Chancroid, LGV, all 2 to 3 months. So incubation period of 2 to 5 days, 2 to 7 days, anything less than a week. Think of herpes, think of chancroid. Yeah? Then is the question telling me that their ulcers are recurrent? They are happening again and again. If they are, think straight away about herpes. Straight away about herpes genitals. Okay, because herpes is the only genital ulcer which keeps recurring. There is a history because we know that HSV goes and circulates into the dorsal root ganglion, and so there is reactivation that can happen. So we have a primary episode of herpes, and then we have secondary episodes, and we have recurrent episodes. Right? Then sometimes they talk about evolution, which is not very, very important for you, but roughly you should know that again, herpes genitalis patient is not present usually with ulcers. Again, there what you would be given the history of erosions. Erosions are superficial, ulcers are deep. We know that from our basics. Okay. So herpes genitalis patient, when they're talking about herpes genitalis, they will give you vesicles. They will give you erosions, which are painful, which are recurrent. Again, ulcer hardly there. Okay. But if they're talking about a papule which developed into a pustule and an ulcer, then they're talking mainly about chancroid. If they tell in the question that there is a transient ulcer that formed, which was asymptomatic, we already know that we're talking about LG. Then how many ulcers are there? How many lesions are there? Is it a single lesion? Are there multiple lesions? Are there few lesions? So how do we differentiate? Syphilis is always a single lesion. The ulcer of the syphilis is called as chancre, and it is always a single lesion. Chancroid, on the other hand, can be multiple. But it's not like innumerous, as in the case of herpes. So in herpes, there are superficial, multiple vesicles and erosions. In chancroid, there can be multiple ulcers, but there will be few. There will not be many. There will not be hundreds, like tens and twenties of them. A syphilis ulcer would be single. LGV, I told you, hardly we get a single ulcer. And Dominguenosis, again, usually you get a single ulcer, but it's so beefy, so exuberant, it's covering so much of area that you know. Okay, so single ulcer, syphilis, few chancroid, and many herpes. Okay, then are the ulcers painful or painless? Painful ulcers, we know we're talking about chancroid and we're talking about herpes. Painless, mostly when they talk about painless ulcer, they refer to syphilis. So in syphilis cases, they would make it a point to mention the term painless because a syphilitic chancre is painless. Dominguenosis is also usually not very painful, but it's very uncomfortable. It's a beefy, exuberant granulation tissue that the patient is carrying. So it's uncomfortable, right? But painless is syphilis. Painful, think of chancroid and herpes. When they want to ask you about dominguenosis, painless or painful would not really help in the question. They'll be giving you more about it, right? So painful, herpes and chancroid, painless, syphilis. Bleeding. So bleeding can happen usually in chancroidal ulcers. They bleed on touch. So they tell you this, they bleed on touch. Chancroidal ulcers bleed on touch. Chancre does not bleed on touch, right? So bleed on touch is chancroid. So these are the things that you might get in history, and with each point I'm telling you what should be your diagnosis. So sometimes they give you more information, but sometimes it's very little information and you have to answer according to that. So use this. So here I've enumerated in the table, I've tabulated the major differences. When we're talking about chancre, for your purpose, consider it as single ulcer, and for chancroid, consider it as few. Well-defined ulcer. A chancre is always, chancre is syphilis. Chancre is single, well-defined, clean, button-like, doesn't bleed with shortening. All these features are characteristic of a chancre. So they may give you single, they may give you painless, they may give you well-defined, clean, and they tell you button-like sometimes. Button-like because there is induration. So if you feel the chancre, you can actually feel it. You can feel that rubbery consistency. It has induration at the base. So it has a button-like ulcer and shorter lymph node. Chancroid, on the other hand, few or many ulcers which have ragged margins. They do not have a well-defined margin. Very dirty looking base, and they're soft. That's why they're called as soft chancre. There is no induration in an ulcer of chancroid. So it's a soft chancre or a soft ulcer, where there is, if you feel the ulcer, you will not be able to feel the induration, and it bleeds to touch. Okay, and you get lymphadenopathy, which is painful, usually unilateral. Herpes genitalis, on the other hand, as I told you, presents more with vesicles, numerous vesicles and erosions, which have a polycyclic margin. Polycyclic margin is again a characteristic of herpes. They can be clean, they can be little woozy, they're again soft, there is no induration, they are actually erosions, they're not even ulcers. And you get painful bilateral lymphadenopathy. Now, in herpes, it also depends on what stage of herpes the patient is in. If it's a primary stage, there'll be a lot of constitutional symptoms, there'll be a lot of erosions, there'll be a lot of lymphadenopathy. Whereas secondary stage or recurrent herpes is less symptomatic. So less erosions, less surface area involved, less pain, less lymphadenopathy, and almost nil constitutional symptoms. Right? Then coming to Dominguenosis. Dominguenosis again usually presents with a single ulcer, which has a very beefy base. So it presents with exuberant granulomatous tissue, which is beefy, which is firm, which bleeds on touch. And as I told you, it presents with pseudobubo, which is presence of a Dominguenosis ulcer over the lymph node, over the inguinal lymph node. So there is no lymphadenopathy, but you think there is lymphadenopathy. So that's called a pseudobubo. It's not actually a bubo, but it is the presence of Dominguenosis ulcer at that site. Okay. So based on these examination findings, you can differentiate between different genital ulcers. So mostly an examination, something will be given and you can pinpoint with that this is the genital ulcer. Genital ulcer is frequently asked, okay? So just make this thing very, very clear and memorize this pretty well. Okay. Then in ulcers, next is sometimes they give you history and examination, which is very, very clear cut, or sometimes they will be giving you a relevant investigation, okay? So for example, if they're giving you a dark ground microscopy, if they say in the question that a dark ground microscopy was done which showed motile organisms, which showed fluorescent motile organisms, you know they're talking about syphilis. It's only for syphilis that I do dark ground microscopy because that bacilli spirochete cannot be stained. So I do a dark ground microscopy for syphilis. So if they're mentioning in the question dark ground microscopy, you say it's syphilis. Now, sometimes there's a twist in the question. They give you the history and examination that we discussed, and they ask you what would be your next step. Okay, so they're not saying that they did a DGI. They might ask you that a patient, a truck driver, presented with a single painless ulcer on the glans. What would be your next test? Single painless ulcer. Single painless ulcer. What would be syphilis? My next test would be dark ground microscope. So you should also know one investigation which is relevant to each ulcer. So for syphilis, it is dark ground microscope. What do you do for chancroid? For chancroid, you do a gram stain. We do a gram stain, and what do we look for? We look for railroad appearance or rail track appearance or fish and swarm appearance or fish trap appearance. So in which you see multiple cocobacilli which are arranged in a chain. So that is gram stain that you see in chancroid. Spool of fish appearance, railroad appearance, track appearance. So different names given. So when they say, suppose they're giving you a patient presents with few painful ulcers, short incubation period, bleeds on touch, what would be your next investigation of choice? It would be gram stain. Right? Similarly, if I'm talking about herpes genitalis, what would be my investigation of choice? I'll do a Zang smear. Zang smear, look for MNGs, look for acantholytic cells. So Zang smear is for herpes. So if multiple painful polycyclic erosions, short incubation period with lymphadenopathy, with oral erosions probably, what would be your test of choice be? It would be Zang smear. Then tissue smear. Where do I do tissue smear? In Dominguenosis. In Dominguenosis, I told you this exuberant, beefy granulation tissue. So you actually take a tissue, smear it on the slide, and look for safety pin appearance. So safety pin appearance is the classical finding that I see in Dominguenosis. And how do I do that? I do a tissue smear. How do I stain it? I stain it with Giemsa stain. So sometimes they may not give you tissue smear, they may say Giemsa stain. So that also you can do for Dominguenosis. Clear? So these are the relevant investigations. For LGV, LGV is for Trichomoniasis, and there's no specific test that we do. Okay, there can be complement fixation test they can give you enzyme immunoassay, but usually if they are trying to refer to LGV, they will give you roof sign. Roof sign on examination is something that we usually give you for LGD. What is groove sign? Groove sign is when there is involvement of inguinal lymph nodes, there is involvement of femoral lymph node. So the Pop-Potts ligament, which is connecting these two nodes, it becomes taut. Two lymph nodes involved in between. There's a groove which is formed because the Pop-Potts ligament becomes taut here. So groove sign is specific for LGD. Okay, so these are the relevant investigations that they give you. So some pictures. So I told you gram stain for chancroid, stool of fish or railroad track appearance, in which I see these gram-negative cocobacilli which are arranged in chain, just like a school of fish. Then Zinc smear, what do I see in Zinc smear? I see multinucleate giant cells with a lot of acantholytic cells also. Okay, so but the classical thing is multinucleate giant cells. Acantholytic cells are more classical for autoimmune blistering disorders. For herpes, what is important? Multinucleate giant cells. So multiple, so as you can see, multinucleate giant cells can be seen on Zinc smear in a patient of herpes genitalis. Tissue smear, as I told you, we do for Dominguenosis, where I see safety pin appearance because of the peripheral condensation of the cytoplasm. There is safety pin appearance of the organism, right? Dominguenosis is caused by Klebsiella granulomatis. So sometimes they even ask you what is the organism. So syphilis, Treponema pallidum, chancroid, Haemophilus ducreyi, herpes, HSV, Dominguenosis, Klebsiella granulomatis, LGB with chlamydia. Okay. Then, so this is mostly about ulcers. I discussed how the history is, how the examination is, what are the specific relevant findings in the examination which can help you with the ulcer, and then what is the one relevant investigation. Okay. Sometimes they can ask you about the treatment part also, but that's theoretical, so I did not put in here. So you can read about it, you know acyclovir, you know benzathine, penicillin, you know all of that. So I'm not going into the treatment part. But here, with this approach, you should be able to categorize different types of genital ulcers. And it should be a very easy job to you to find out the positive organism, the test of choice, or what are the examination findings that you might get. Okay. So with this, we'll move on to discharges. So now in discharges, there are two kinds of discharges. So one is vaginal discharge, the other is cervical or urethral discharge. Now the lining of cervix and urethra are similar, so the cause of their discharges are also similar. So we study cervical and urethral discharges together and vaginal discharges separate. Okay. So when we are talking about a discharge patient in a female, we have to figure out what is the source, whether the discharge is coming from the cervix or it is a vaginal discharge. Okay. So in the question, you will be given that whether it is a vaginal discharge, whether it is a cervical discharge. Also, very, very rarely they'll give you cervical discharge. So usually either they'll give you urethral discharge or vaginal discharge. There are hardly any questions on cervical discharge in dermatology. Okay. In gynecology, they may talk to you about PID. So urethral discharge or vaginal discharge, right? So now coming to urethral discharge. So first, when you get urethral discharge, it's like I think in NEET PG last year they gave you an image where they give you a urethral discharge. Remember, we have to here differentiate broadly into two, whether it is gonococcal or non-gonococcal. Okay, now gonococcal urethral discharge, which is called as gonococcal urethritis, is caused by Neisseria gonorrhea. Neisseria gonorrhea, that's the positive organism. One. Second thing, the discharge is usually associated with constitutional and urinary symptoms. Right now, I'm talking about gonococcal discharge. So, positive organism, then constitutional symptoms and urinary symptoms are usually associated with this kind of discharge. So, they give you some burning, micturition, fever, malaise, anything, any constitutional or urinary symptoms. Third, the kind of discharge. So, in GU, gonococcal urethritis, the discharge is profuse, it's thick, it's yellow, profuse, thick, and yellow discharge. So even when they give you an image, you can make out it's a very yellow discharge, it's a very profuse discharge, it's a very thick discharge. So, okay, Then the last thing that you do is a staining, a gram stain. So in gram stain, there are two things you look for. One is presence of polymorphonuclear mucositis, PMNs. If you have more than 5 PMNs per high power field, you label that patient as urethritis, that the patient has urethritis. I have to still find out whether it is gonococcal or non-gonococcal, but the patient has urethritis or urethral discharge. Then, in gram stain, if you find gram-negative diplococci, which are present intracellularly and extracellularly, you straight away label this patient as gonococcal urethritis. Okay, so based on constitutional symptoms, the type of discharge that you got, and on gram stain, presence of this gram-negative intra and extracellular diplococci is all suggestive of gonococcal urethritis. So either of these three things will be given to you when they're talking about gonococcal urethritis. Vis-a-vis, let's talk about NGU or non-gonococcal urethritis. One, you should know what it is caused by. So NGU is caused by chlamydia, by HSV, by ureaplasma, by mycoplasma, by trichomoniasis, so numerous organisms. Okay, so it can be caused by all these organisms. What is the characteristic of the discharge? It is usually not associated with a lot of constitutional symptoms or urinary symptoms. So it's going to be very asymptomatic. So patient lives with it. Patient does not even realize it. That is why we see more complications with non-gonococcal urethritis as compared to gonococcal urethritis. Okay, so now coming back, so less constitutional symptoms, hardly any urinary symptoms, and now the discharge here is scanty. It is watery, scanty, watery looking discharge. So there is no profuseness, there is no yellowness, so it's scanty, very watery discharge, which is present in non-gonococcal urethritis. So depending on what the kind of discharge is, you will be able to differentiate. Then third, if you do a gram stain, what do you see? You see just PMNs. You do not see any gram-negative diplococci, right? So only PMNs, no diplococci is mentioned. So in urethral discharge, you should be knowing how to differentiate between NGU and GU, and with these points, you can easily differentiate, right? Similarly, we'll go about cervicitis. So cervical discharge with gonococcus or non-gonococcus, similar features. Okay, but usually when we talk about cervical discharge, the discharge may not be very profuse even in gonococcal urethritis. Because see, when there is cervical discharge, the discharge has to travel throughout the vagina. So it is not profuse. Yes, when you do a PS, you might see a profuse discharge. But patient person may complain of profuse discharge. Okay, so this is how in urethral discharge you differentiate between gonococcal and non-gonococcal urethritis. So this is a gram stain of, so you would all have guessed this is gonococcal urethritis, where you are seeing Neisseria gonorrhea. These are gram-negative diplococci, which are present together. They're present inside the cell and they're also present extracellularly. A very, very important and diagnostic feature of Neisseria gonorrhea or gonococcal urethritis. Right. How do you culture? So sometimes they ask you this. So in gonococcal urethritis, the culture medium is Muller-Hilton Carr medium, which is enriched with chocolate horse blood. So MHA enriched with CHB. So if you ask you one, the best test, it would not be gram stain. It would be culture. So culture would be my gold standard test, or my definitive diagnosis would be through culture. Right. So that is about discharges. Again, I'm not dealing with the treatment part, but just a word about treatment and discharges. So when we are treating a patient of gonococcal urethritis, we also give treatment for NGU there. Why? There may be mixed infection. And how do you differentiate NGU and GU? So if a patient has both infection with both GU and NGU, just imagine the discharge will be profuse. You will not be able to see the watery discharge. If you do a gram stain, you will see PMN, but you will also see the diplococci. So a patient of GU or gonococcal urethritis is assumed that he has NGU also. So when we are giving treatment to a patient of GU, we give azithromycin. We give azithromycin. Why? Because we are also targeting NGU. Because we cannot be sure in the patient of gonococcal urethritis whether there is a coexisting NGU or non-gonococcal urethritis or not. Okay. So along with your ceftriaxone, which is for gonococcal urethritis or oral cefixime, you always add 1 gram of azithromycin. Whereas if you're sure that there is no GU, if you're watery discharge, scanty discharge, if you do a gram stain, you do not see any diplopropyl, and you can safely label a patient as NGU, you can just give azithro 1 gram stain. Okay. Next, coming to vaginal discharges. So when we talk about vaginal discharges, there are a lot of questions that are asked again. Sometimes they ask you what is the most common cause of vaginal discharge, and you try to look for VV and you mark that. So remember, the most common cause of vaginal discharge is physiological. So vaginal discharge, the most common cause, if there is an option of physiological, always mark physiological discharge. Okay. Now, if they talk about most common cause of vaginal discharge and you do not see physiological, or in the question they are asking you about what is the most common cause of pathological vaginal discharge, in that case, you mark bacterial vaginosis. Here. So bacterial vaginosis is the most common pathological cause, but my physiological discharge is the most common cause of vaginal discharge in general. Then, as I told you, you always try to differentiate whether we are talking about cervical discharge or vaginal discharge. In cervical discharge, treated as the gonococcal and non-gonococcal, as we discussed. When we talk about vaginal discharge, we think about 3 main organisms here: Candida, Trichomoniasis, and bacterial vaginosis. Out of which is the most common? Bacterial vaginosis. And sometimes when students ask us, what is physiological discharge? How do you differentiate whether it is physiological discharge or pathological discharge? So physiological discharge is limited, 4 to 5 ml. It's not diffuse. It's white or transparent. It can be thick or thin, but it's usually odorless. So it's odorless, it's usually scanty. It might stain the undergarments, but does not make them wet, actually. And there are more around some times of the day. It's like time of ovulation, like premenstrual. You might get a little more discharge. Then they're odorless and they're symptomless. There is no itching, no burning, no associated with this. Okay, so my physiological discharge is mild, it's scanty, it doesn't wet the undergarments, and it is odorless, and it is symptomless, right? So, but pathological discharge would always be foul smelling and it would be very symptomatic. Okay, so this is how we differentiate a physiological and pathological discharge. Now, when we are evaluating a patient of vaginal discharge, I already told you, try to find out the source, you do a PS and see whether the discharge is coming from the cervix or from the vagina, and you take appropriate specimens. Okay, so this I think, yeah. So coming to my most common cause of pathological vaginal discharge, which is bacterial vaginosis. So my bacterial vaginosis is the commonest cause of vaginal discharge, as I told you, and in this, more than 50% patients are asymptomatic. Okay, so what is a good thing about bacterial vaginosis is a lot of people say, a lot of people also say we should not be treating it as a STD, right? Because bacterial vaginosis is also seen in nuns, seen in people who are not sexually active. So that is why this is one STD where you do not give partner treatment. Okay, so like in all other STDs, whenever we diagnose a patient of gonococcal urethritis, a patient of syphilis, herpes, we always tell the patient that we should be ideally treating your partner as well. We try to do contact tracing, we try to trace the partner and try to provide them treatment also, because we know that these diseases are sexually transmissible and there are high chances that the other person has got the disease transmitted, right? But bacterial vaginosis is one STD where we do not recommend partner treatment, and this is a question which is commonly asked. So no partner treatment needed for bacterial vaginosis. Now why? Because bacterial vaginosis is actually caused by alteration in the microflora. It's not like a pathogenic organism is being transmitted to a person through sexual route and he's getting bacterial vaginosis. She's getting bacterial vaginosis. It is actually the alteration of the normal flora. So normally, what do my vaginal mucosa contain? It contains lots of lactobacilli. Now these lactobacilli are superseded, are taken over by a lot of anaerobic and gram-negative bacteria. These are Gardnerella vaginalis, Mycoplasma hominis, Mobilincus, Prevotella. So these are all anaerobic and gram-negative bacteria which now form the predominant population in the vaginal flora. So they replace the lactobacilli. So it's alteration in the microflora which leads to bacterial vaginosis. Okay? So that is why we do not do partner treatment. Now, so that does not mean BV does not happen with STD. There can always be a history of STD here, right? So then there is a clinical criteria which helps me diagnose BV. So you know about Amsel's criteria. So we have to look for Amsel's criteria, and presence of 3 or more of this helps me diagnose bacterial vaginosis. So what is there in Amsel's criteria? First is the clinical findings. What is the kind of discharge? In BV, I see more of homogeneous discharge, a thin discharge, a whitish to watery discharge which smoothly coats the vaginal wall. Okay, and it may be symptomatic, may be associated with uveitis. So it's not necessary that all BV patients will be symptomatic. Homogeneous, thin, white discharge which is smoothly coating the vaginal walls, right? And it's not a very profuse kind of a discharge. It's an okay kind of a discharge. So discharge 1. So when you get this patient, you do a pH paper test or litmus paper test. You look for pH, and the pH here is alkaline. It's more than 4.5. In fact, BV and T, both these are basic. In Candida, I get acidic pH. In bacterial vaginosis and Trichomoniasis vaginalis, I get basic pH. So pH is more than 4.5. Then, when I'm examining the discharge, I notice a fishy odor to the discharge, which is very, very characteristic of bacterial vaginosis, and I call it Whiff's test. Whiff's test. What is Whiff's test? Either you get a fishy odor directly, or if in the discharge you just add 10% KOH, then you get a fishy odor because of release of amines. Okay, so this release of fishy odor on putting 10% KOH on the discharge is called as Whiff's test and is very, very characteristic of bacterial vaginosis. So you examine, you look for fishy odor, you do the pH test, and then you do a stain, gram stain. And what do you see? You see clue cells. Okay, so clue cells. Let me see if I have a clue cell. Yes. So clue cell is, there is a vaginal epithelial cell, and it is bombarded with a lot of bacilli, a lot of stippled appearance of the vaginal epithelial cell because of a lot of anaerobic and gram-negative bacteria. Now, normally also these bacilli may be present in a vaginal mucosa. So if from a normal vaginal mucosa also, if you try to make a smear, you can see a clue cell. So the diagnostic thing is more than 20% of these cells should be clue cells. So you should have more clue cells. Just identifying 1 or 2 clue cells is not sufficient, but that's not again very relevant for you. You should remember this criteria, how the discharge is, presence of clue cells, a pH which is more than 4.5, and a fishy odor on putting 10% QH of Whiff's test. This is called as Amsel's criteria, and this is used to diagnose bacterial vaginosis. Come to trichomoniasis. Okay. Now, trichomoniasis, again, I told you men, it causes NGU. One of the causes was Trichomoniasis vaginalis. In women, it causes vaginal discharge. And what is the kind of vaginal discharge that I get? Here, the typical history would be greenish, frothy discharge. Look at the discharge. You can see the froth. So, greenish, frothy vaginal discharge associated with pruritus, associated with irritation usually. It's hardly asymptomatic. So greenish frothy discharge is a characteristic of Trichomoniasis vaginalis. Okay, another thing, Trichomoniasis is actually a flagellate protozoa. It's not a bacilli or anything. It's a protozoal disease. So it's a flagellate protozoa. They ask you this also. It's caused by Trichomoniasis vaginalis, which is a flagellate protozoa, giving rise to greenish, frothy discharge associated with some irritation, some itching. Again, if you do a pH, you find a pH which is more than 4.5. Right? Now, another important thing that I see in Trichomoniasis is if you do a PS examination, you see strawberry cervix. So strawberry cervix is seen in, again, another important question, Trichomoniasis vaginalis. Right? So this is my second discharge. So easy. There, it's very different. The discharge is different. pH is same, but the discharge is different. It's greenish, frothy discharge. Coming to the last vaginal discharge, which is vulvovaginal candidiasis, which is caused by Candida albicans, which is a yeast. Now, how does it present? Now, Candida, when we talk about VVC, you should know VVC can happen either in immunocompetent individuals where Candida albicans is the major cause, or it can happen in little immunodeficient patients, patients of HIV, patients with diabetes, patients on chemotherapy. So in them, you get more history of recurrent vulvovaginal candidiasis. Okay, immunocompetent patient, usually there is a single episode. So C. albicans is my major pathogen, but it can also happen with C. glabrata, C. krusei, and other kinds of candida. Now, what are the symptoms here? The symptoms here is extreme pruritus. So VVC, usually patients are very, very itchy. If you look at the vaginal mucosa, it's very red. It's eroded because the patient scratches so much. So because of so much of scratching, there are erosions which are formed. So patient also gives history that when the patient tries to pass urine, it burns because the urine touches those erosions and the patient has dyspareunia and dysuria, right? Then what is the kind of discharge? Again, very, very characteristic. Here, my discharge is cheesy. It is thick. It is very, very white. It is thick, white discharge, which has a very cheesy consistency. So if you ask the patient tells you that there is a cottage cheese consistency, there is thick discharge, whitish discharge, and this discharge usually flares up pre-menstrual. So pre-menstrual flare, thick, itchy, dysuria, dyspareunia, and presence of this thick discharge. When you even examine, you see this cottage cheese appearance of the vaginal mucosa, and that's even extending upwards. What do you do with for VVC? We do a KOH mount. We try to look for yeast and budding yeast cells and presence of pseudohyphae. Okay, so easy to diagnose again. So all these three discharges are very different. So when you talk about clinical practice, sometimes it's confusing, but when you are given in the exam, they'll be giving you these specific features, and so you'll be able to diagnose them easily. Right? So this is, so what you do for, VVC, you do 10% KOH. So what you do for BB, you do a gram stain and look for Krusell. And for TB, you look for flagellate protozoa. So you see these jerky, pear-shaped bodies in Trichomoniasis vaginalis. So these are my three vaginal discharges. So we talked about ulcers, we talked about the urethral discharge and vaginal discharge. Now coming to nodules. So when we talk about nodules in the genital area, you should think of inogenital warts, you should think of molluscum contagiosum, and you should think of nodules of scabies. We talked about it. Scabies in genital area sometimes can present with nodular scabies. So scabies, it would be itchy. You would be giving some history of itching. Inogenital warts and molluscum contagiosum would be totally asymptomatic. But with molluscum, you will be getting a history of umbilicated papules. Some indentation will be papules, or you would be given Henderson-Peterson bodies. In inogenital warts, you would be given a picture where you would see a warty growth. So all these can present with nodules in the genital area, and all these are STDs. So warts, luscum, and scabies in the genital area come under STI. Next, we come to buboes. I talked about buboes in genital ulcer. I was telling you that we'll discuss it in more detail. So buboes, when they give you, they want you to differentiate between buboes of chancroid and LGV. So chancroidal bubo and LGV bubo, you should be able to differentiate. Remember, with chancroid, remember 3 U's: unilateral, unilocular, and presence of ulcer. So 3 U's is characteristic of chancroid. The chancroidal bubo are unilateral, they are unilocular, and usually, almost always, there will be presence of an ulcer. Whereas LGV, I told you, you hardly see any lesion. The ulcer is transient. The buboes are usually bilateral. They can be unilateral, but they are usually bilateral, and they form multilocular abscesses, right? And in LGV, you can have femoral lymph node involvement, iliac lymph nodes involvement. That's why I said groove sign is seen in LGV, because there is involvement of femoral and inguinal lymph nodes. So my Paupert's ligament will be caught, and you see that groove sign. Okay, so multiple lymph nodes may be involved, multiple types of lymph nodes, femoral, inguinal, iliac lymph nodes may be involved, and with chancroid, you see usually inguinal lymph nodes, so unilateral, unilocular, presence of ulcer. Remember these 3 U's, and most of it is done. LGV, usually you see an undermined margin, which is not there in chancroid, but that's not really important for you. Remember these 3 U's and involvement of what kind of lymph nodes, right? So this is in brief about how do you approach a case of STD. So in this 1 hour, I've tried to cover all the important aspects, important components of STDs, and how do you differentiate. So if you get an ulcer, if you get a discharge, if you get a bubo, if you get a nodule, these are the major questions that you get on STD. So after this, I think you should be able to answer most of your questions of STDs. So now I'm open to answering any queries if you have, and related to this topic, or also something else also related to this topic, or any other queries. So you can tell me your queries, I'll read for them, and I can answer them for you. Okay, so I don't see any queries being posted here. So I think I'll wind up my session here. And try to read each STD in detail. But in the end, when you have to revise, I think this is a good quick revision kind of a lecture that you can see. And with this, I think you'll be able to answer most of your STD questions. Okay. So all the best for your exams. We are here. If you have any queries, you can mail me later. And my email ID is khushbu1401@gmail.com. Or on the, if you are an eProfil student, you can put your queries in the app, or get back to us, and we'll try to answer your queries. All the best. Read well and come on the other side as always.